Hello everyone, another smaller presentation, and this is going to be like the choosing of an initial antihypertensive medication. It's just a pharmacotherapy lecture. This is kind of an addendum to my main antihypertensive lecture. So a lot of this will be drugs you've already seen and kind of repetitive. There is some new stuff in here that I would like you guys to pay attention to for testing purposes, etc. And then overall, I just think this is good for you guys to have an approach for hypertensive emergency. Introduction here, just definitions, just read through those, just make sure everyone is on the same page. Same thing here, just take home point that you do need to be careful with your reduction in blood pressure, so it's not like just completely closing the faucet, so to speak, that it needs to be, kind of taper down. And then also too, hypotension, highlight that is something you always have to be concerned with, even in an emergency. So, too low a blood pressure can be problematic just as much as higher. The other thing too to note that when you can use oral therapy or PO therapy, please do. So this is if they are asymptomatic. So again, this will be an inpatient, typically not at your clinics or whatever, but still, if you can use oral, it's preferred. This is a really good table, and I wish it was bigger, but I believe you guys can zoom in, etc. I can't on my computer. But definitely make sure you, and this is from Up to Date, by the way, if you want a bigger one, or if you're wanting the primary source or whatever of this, but it's parenteral drugs used for the treatment of hypertensive emergencies in adults. So definitely want you guys to look at this. Note the drug, the onset of action and duration of action. That's going to be more FYI. And dosage range from my perspective, but I definitely want you guys to look at the adverse effects and then look at the role and then pay attention there and squint at those, because some will say it's better in pregnancy or not, and they have some really good little notes there. And also to email me if you can't get the table, and I'll get it to you. I'll make sure you know where it's from on Up to Date, etc. Also note too that there is the categorization of vasodilators, which it starts with those at the top, and then adrenergic inhibitors, which goes in the bottom. For my testing purposes, though, please stick to the categorization that I gave in my previous slide. The reason I mention that is because there are some that are under the adrenergic inhibitors that I would want you to know that are beta blockers, for example, or know they're more specific categories, right? If I provide those. That's just one caveat to this table. But other than that, definitely look at it. And like I said, the adverse effects and role columns there at the end are good. And then always with Up to Date, look at the fine print. They put some good stuff in there. And I know it's kind of annoying on this slide. It's super tiny, and like I'm squinting too. I have it actually pulled up on my iPad because it's really hard to read. But so anyways, please pay attention to this table. Put a star on this table. And so parenteral drugs. Again, if you can get away with using oral, use oral, but if not, use parenteral, which means IV, right? Synonymous to IV. Unfortunately, there have been specific studies that really compare these head to head. And so you'll see a lot of these different choices in different hospitals. And it's just really going to depend on your hospital formulary and what they use there or what they use in the emergency room, etc. So that's just something as a student on rotations or as a new practitioner, you just have to learn about your facility. And then a lot of times too, they will have protocols, and they'll have these medications that are on their formulary. First off, we have the nitrates. So these are under the vasodilators on that table category, and they are also known as nitrovasodilators, but this is specifically Nitroprusside and then Nitroglycerin. They both just kind of take home point, and just summary, don't stress too much about memorizing this, but because of its involving nitric oxide, which is a vasodilator, these cause vasodilation and therefore decrease blood pressure. Nitroprusside, sodium nitroprusside, so that's just the name it's given or what it is when it's IV, so that's a specific formulation. For testing purposes, don't stress too much about that. I'll always put nitroprusside. I won't, make you necessarily worry about that. It is very, very quick acting, so this is going to work in 1 minute or less. And then it's fast onset, but it's also fast offset, so to speak. I don't know if that's a word, but it's, it kind of turns on and off very quickly. So minute or less, and then the effects disappear 10 minutes or less. And because of that, you do need to have monitoring because it is very effective at decreasing blood pressure. It is a very effective vasodilator, and you can have drastic drops in blood pressure. But then the good news is its effect typically doesn't last very long. So, but it still can be, can be a detrimental drop in blood pressure. This is recommended dose, just FY from my perspective, but go ahead and look at that. And just note too that there is the maximum duration of 10 minutes because it can have some problems with it, and specifically can have toxicities. And so in general, nitroprusside should be avoided due to its toxicity. So I'd be surprised if it was on a formulary in a hospital, but if it is, just always be thinking about its potential for toxicity. And specifically, this will be a review from my other slides, but it causes a cyanide toxicity that can be fatal. So, and this can be something that can happen as quickly as in 4 hours. So anyways, and that's part of the reason they don't recommend long treatment too, because of that. And be careful too with renal function. So in renal impairment, you have an increased risk of toxicity, etc. And then also to please note the antidote that I mentioned in my other slides, and make sure you guys know that for testing purposes. The other thing to note too with nitroprusside is it should be avoided in patients with acute myocardial infarctions, coronary artery disease, cerebral vascular arterial disease. You also need to be concerned if the patient has elevated intracranial pressure, renal impairment, or hepatic impairment. So a lot of limitations, plus the toxicity. Again, not used a lot, not super popular, but I just put it out there because it is still around, it's still available, and you may see it in some of your facilities. One thing, that you can to mitigate the toxicity here, just note that it can be, shorter amount of time, lower doses. It's just a less exposure basically, but you can just read through this, but don't stress about memorizing the dosing and stuff for me. So here are some more limitations, so just go ahead and read through those. Note it should not be used in pregnant women, so please put a star by that. And then I mentioned, liver, kidney function are concerned, or you have to avoid that with impaired renal function or impaired hepatic function. And then it's also expensive, so on top of all that, again, probably won't see it, but just because it is still available, want to make sure you guys know about it. Nitroglycerin. So this is one that you probably will see. This one's used, it comes in a lot of different ways, but you can administer it IV. It's similar to nitroprusside, but then without all of the negative effects, right? So without having to worry about the cyanide toxicity. But when you compare it to other antihypertensives, it is kind of problematic because you'll notice here the second bullet point that there is some variability from person to person, and so it's not as quote unquote predictable of a drug when you're trying to decrease blood pressure. So that is something that you have to be concerned with. And so typically it is an adjunct to other IV antihypertensive medications. So it's typically not given monotherapy. Here's the initial dose. Onset action's quick. You notice that. Adverse effects. Headache's the big one. That's because of the side effects. You get people complain about that. And then tachycardia is another one. I mentioned before you don't have to be concerned about cyanide, so that is an advantage of that. And then here is a specific type of anemia that is a rare but serious adverse effect that you have to be concerned with the person being on nitroglycerin long term, so more than a day. Calcium channel blockers. So you'll notice I don't have the complete list here. We're just specifically talking about Nicardipine and Clevidipine. So those are the two of the calcium channel blockers. So that's what I was saying earlier. Pay attention to my categorizations because that table we went over before and I told you guys to study, it has these listed just as vasodilators, which is true. They do cause vasodilation, but for my testing purposes, please note that they are specifically calcium channel blockers. First up, we have the Clevidipine. This is a very short acting, so it's considered an ultra short acting, used IV, and can help with severe hypertensive. So this you'll see this being used for hypertensive emergencies, and more specifically for a post-operative hypertension. You will see that in hospitals, and they'll be on protocol. Here's some contraindications, so just go ahead and look at that. One that's kind of interesting that I forget about, or patient or practitioner forget about, is this known allergy to soy or eggs, and this is because of what it's made with. So it's actually made with something that can cause a cross sensitivity there. And this one's just FYI, but it just basically hasn't been compared head to head. And then there's the dosing there. Nicardipine. So this one, if, like I mentioned in another presentation, is a type of dihydropyridine calcium channel blocker that can be given IV. A lot safer than Nitroprusside, which probably isn't that surprising because the Nitroprusside is pretty messy, right? And this one can be used in most hypertensive emergencies. So it can be used in a pregnancy-induced hypertensive emergency as well. It should be avoided in acute heart failure. And then it needs to be used with caution if a person has coronary ischemia, because it can actually make the ischemia worse. Now we have the dopamine 1 agonist. So this one we talked about in our slides. Again, please note it or label it as a dopamine 1 agonist. It is also a vasodilator. That table says that, but be familiar with this mechanism of action, etc. This one is unique in that it is the only one listed that is a dopamine 1 receptor agonist. So this has some advantages. One is it can be safer or be more effective in patients who have renal impairment. So that is something to think about. And then the dosing there, you just go ahead and read through that. It should be used in caution with patients who have glaucoma or patients who have increased intracranial pressure, and basically it causes an increase in pressure for the person who has glaucoma, which is intraocular pressure, which we'll talk about more later once you guys, I think it's an ENT module, but basically increased pressure for a patient with glaucoma isn't a good idea. It makes things worse. And then you can read through the other point there. Next, we have what is on the bottom half of the table is the adrenergic inhibitors. So these are adrenergic blocking agents. And you'll notice these Esmolol and Labetalol, which are interesting. And so Labetalol is actually a beta blocker and an alpha blocker. So it's beta adrenergic and alpha adrenergic. So it has kind of a dual mechanism of action, if you want to think of it that, or label it as such. You're going to read through this, see what its uses are there. It can be used for most hypertensive emergencies. It can be used in pregnancy safely, and then so it's also used in postoperative hypertension. This one should be avoided if a person has uncompensated heart failure, because it can exacerbate that and make that worse. And then it also needs to be so you notice here, heart failure, bradycardia, again, can make those things worse. But then also you have to think about people with breathing problems, so asthma or COPD, because this can actually cause the obstructive or reactive airway, so it actually makes the asthma worse or the COPD worse. So that's something to note there, and it's because of its effect on its beta receptor. So you actually have beta receptors in the lung, which we'll talk about more in the pulmonology lecture, and there's specific drugs that we use to target that actually help person breathe. But because this is a beta blockade, it actually can hurt the person who has those issues. So something to note there. And this slide, just go ahead and read through. It's just mainly FYI. And then Esmolol. This is another interesting one. This is a cardioselective beta blocker. So it is good, or can help with hypertension. And then this is one too that can help with perioperative hypertension, aortic dissection, but it should be avoided use in acute decompensated heart failure, because like with the Labetalol, it can make that condition worse. Then we have some other agents that are interesting kind of mix here in that, so the phentolamine is actually an adrenergic inhibitor, where the hydralazine is a vasodilator, and then the enalaprilat is a vasodilator. So you gotta make sure you kind of keep these straight, but these two are vasodilators at the top, and then this one is a adrenergic inhibitor, the phentolamine. But first, vasodilator here, hydralazine. Just go ahead and read through this. It isn't less predictable, so it is something that's usually avoided because it has a prolonged effect, and then it's a quote-unquote unpredictable effect. And so something, again, that's not usually first line. I mean, you may still see it. It is still around. You see it some outpatient too. It's given orally for some different things. But as far as hypertensive emergencies go, unpredictable and prolonged effect make it not favorable. So this one can be used for pregnant women, but it is limited. So they typically prefer the Labetalol or Nicardipine over hydralazine for pregnant women. But it is something that's, it's technically it can be used and it is out there, but not first line for that. And then one other thing too, before as far as adverse effects go, kind of related to its unpredictability, it can cause sudden precipitous drops in blood pressure, and this is for all patients, not just pregnant women. Tachycardia, flushing, headache, vomiting, and then it can make angina worse in a patient who has problems with angina. Enalaprilat. So this one, you notice the spelling, it looks kind of like enalapril. So it is actually a derivative of an ACE inhibitor, enalapril, but it's the IV form of that. This one's also unpredictable, unfortunately, and it has a long duration of effect. So this one is also rarely used, not typically used. You have to also worry about the precipitous fall in pressure, which just means that just these big drops in blood pressure, and again, unpredictable, etc. Also, there's variable responses between patients, and then headache and dizziness too can happen with this medication. Please note though too, like with all ACE inhibitors, and so we review for you guys, it is contraindicated, absolutely contraindicated in pregnancy. So definitely avoid in pregnant patients, but it also has a couple more contraindications: severe renal artery stenosis with glomerular ischemia and severe hyperkalemia. Phentolamine. So this is an alpha adrenergic blocker, non-selective. Limited use, not super popular. It's considered an alternative option. For example, for a catecholamine excess. So this is like something, for example, if someone had a cocaine overdose, this may be used for that. Or if they had tyramine ingestion with person taking an MAO inhibitor, monoamine oxidase inhibitor, MAO inhibitor, which is a type of antidepressant that we'll talk about later, or it's a class of antidepressants rather that we'll talk about later. But if they have a tyramine ingestion, that can be really bad news for them. Here's just the dosing of that, just FYI on that. And as far as adverse effects go, it can cause tachycardia, flushing, headache, nausea, vomiting. Oral drugs. So just in general, just a little bit of pharmacokinetics or whatever, the oral absorption and the oral administration of these antihypertensives is slower than IV, the parenteral. So this is typically where a person does not have severe hypertension and it is not symptomatic, and you're not as worried about acute end organ damage. So you will sometimes see oral antihypertensives given in an emergency room or in an inpatient, and again, it's going to be patient specific. It's going to depend. And as a new practitioner, don't stress too much. There should be protocols, or you'll be with more experienced staff, so you can ask them, when do they give IV or whatever. And then again, hospital protocols too will be a good guide to see when when you give oral, when do you give IV. Oops. Okay, and that was the last slide. So that is it for the overview of treatment of hypertensive emergencies, mainly with IV drugs, and then you can go PO or oral some. But anyways, feel free to email me directly if you have any questions. And thank you guys for your time and attention. I'll talk to you later. Bye.